thank you very much to Fordham University and Columbia University for this timely symposium, and in particular to Sophie Mitra, who actually is one of the pioneers in study and research for social protection and person with disabilities. I think everybody has put once in their bibliography the 2005 paper of Sophie on social safety net and person with disabilities in developing countries. Why do I say that this symposium is timely? Is I think, of course, with COVID-19 crisis, social protection is everywhere. But I would say in a broader perspective, I think there has been a significant evolution of the understanding of the role of social protection in general, and for persons with disabilities in particular in the last decade. And we have seen a very progressive and unsteady shift from a focus on basic income replacement, incapacity to work, towards social protection as a vector of support for inclusion and participation. I insist on the unsteadiness of this shift. If you look at, for instance, the joint statement of the International Labour Organization and many other UN agencies of 2019, there is a growing consensus on the fact that inclusive and universal social protection system should provide for persons with disabilities across the life cycle, basic income security, coverage of healthcare costs, but also coverage of disability-related costs, including for those who seek socioeconomic participation. And I think it makes a great connection with the session which just finished with regards to employment. There is this growing understanding that you cannot have inclusive labor market without inclusive social protection. And those two, it's not either social protection or employment, it's actually social protection and employment working together. Unfortunately, if you look at low and middle income countries, less than 20% of people who would be considered with significant disability get access to disability support from social protection systems. And if you look at low income countries, it's less than 1%. So between the emerging consensus and the reality, there is a significant gap. And when those programs exist, we know that there are many design issues that might undermine access or that might undermine actually impact on inclusion and participation. And we have with us today several great speakers that will address critical issues that we are trying to fix in making social protection inclusive. We will first see with Mario Spiezio the issue of data and how government and other stakeholders can actually get the data they need from household surveys. Then we will see with Shaffa Hameed and Morgon how a universal disability allowance may still face some issues in terms of reaching out person with disabilities and what can be the barrier in terms of access and uptake with a specific case study in the Maldives. And with Karen Fisher and Sandra Gendera, we will see, I think, one of the probably most complicated issue we face in trying to make social protection inclusive, which is how do we reach out? How do we ensure that most marginalized groups, in particular people, for instance, with psychosocial disabilities, how do we ensure that they get the support they are entitled to? And I think those are only three of the big issues we are facing. But in 1 hour, if we can touch upon those, I think it would be already fantastic. So without any further ado, I would like to give the floor to Mario Spiezio, who is an associate social affairs officer with the UN Department of Economic and Social Affairs. You will have 13 minutes-ish to make the speech. And as agreed, I will have a sonic alarm at 13 minutes just to signal that you might arrive to the end. Mario, okay. The floor is yours.
Thank you so much for the introduction, Alex, and of course to Fordham for organizing this conference, which is, as you said, very timely. And I mean, like you basically presented half of what I had to say, so that's already great. So people just know why social protection matters and why disability inclusion matters. So I'm gonna just share my screen so that you can see my presentation, if that's fine with you. Share. All right. Can you see the presentation?
Yes.
Okay, all right. Let me just put it like full screen and then move on. So, as it was mentioned, basically I carried out this work on social protection and persons with disabilities to better understand what is actually that we can learn on the basis of existing data and survey instruments, particularly household budget surveys, because they provide an opportunity to measure and understand what is actually the condition of both persons with and without disabilities, particularly with regards to socioeconomic outcomes. And in the presentation, I will just first, of course, like discuss why this research matters and why we should know more about like social protection coverage and persons with disabilities, and then basically provide a quick overview on how disability has been conceptualized in the past decades, measured and integrated into data collection. And then I will just move into more greater discussion on household budget surveys, and so basically how disability status and inclusion is connected to social protection and information gathered on this specific topic. And then the last part, it's more about like the analysis, which is divided in two parts. One is an assessment of survey instruments, the 4 questionnaires, to understand how disability is measured and captured. And then the last part, it's more about like an analysis of microdata, providing a few takeaways of this preliminary work. And really welcome like your comments even after this conversation. So, as mentioned, social protection, that's more than a tool that just looks at and aims to reduce poverty, but can strengthen basically individual and households resilience, as well as just as a tool that can promote social inclusion and economic inclusion. And Agenda 2030 recognizes the role of social protection, particularly under the Sustainable Development Goal 1, which is about the eradication of poverty. And particularly what this goal says is that everybody, all people should have access and should be covered by comprehensive social protection systems, particularly like vulnerable groups. And among like vulnerable groups, the 2030 Agenda recognizes persons with disabilities, which are also defined as agents of change, not just beneficiaries. But the implication of this statement is that persons with disabilities should have access and benefit as much as other persons from social protection systems. The problem that we face today is that we have like evidence, for instance, on disability benefits, but we might not know what's the condition of a person with disability with regards to coverage of other social protection programs, as well as it's not very comprehensive in the sense that we have like in-depth case studies for national programs, but we might lack this more comprehensive overview that allows us, for instance, to monitor the implementation of the SDGs. And that's the reason why then just the Department of Economic and Social Affairs and myself decided just to move on with this project. And this part, basically, I just would like to go back quickly on how disability has been conceptualized, because what disability is and conceptualized actually affects the way we collect data and who is considered living with a disability. So we can just group, let's say, 3 main models that have been used so far. And the first is the medical model, which sees disability as an individual impairment. So something that can be fixed and should be fixed through healthcare, let's say, and by healthcare professionals. Whereas if we look at a model that is, let's say, the social model, disability stems from basically an environment that is not enabling. So constraints in the environment basically affects the ability and
Mario, could you just speak a little bit slower? I think in terms of captioning and interpretation, it's a bit challenging.
Which doesn't help like the participants, so sorry. And in terms of the social model, basically it's a model that tries to understand whether the environment is enabling. So whether persons with disabilities have an opportunity to participate on equal basis with others. And instead we have like the third model, which brings together the medical and the social model. And basically it's still see disability as basically at the individual level as an impairment, but in interaction with the environment. So basically, whether like a person live with a disability or has difficulties in carrying out certain activities, it's basically related to what extent then the environment allows this person to function and operate as other people without any like constraints to their opportunities and rights. And you can see that this model have implications for like the way we measure and identify persons with disabilities, in the sense that if we look at the medical model, in basically like a questionnaire, you might find just basically a questionnaire asking self-identification of like a disability status, basically whether you do or you don't have like a disability, yes or no, or just like a list of medical conditions defined as such. Instead, in a social model, you would basically measure disability in a survey by assessing whether like the environment is enabling. So basically whether persons with disabilities can enjoy their rights and opportunities, or for instance, individual participation. But this is quite tricky because participation is culturally situated, so it might differ in terms of what participation is across countries, whereas in the last model, which brings together the medical and the social model, we would basically assess difficulties in carrying out basic activities, which should proxy basically participation. And these basic activities go from seeing, speaking, walking, and hearing, and that might also include self-care as well as concentrating, remembering. And so far, these questions have been integrated in three main data sources, let's say. The first two are mainly administrative data, which provides information usually about people who participate and are covered by social programs. And in this case, of course, we have information for those who participate and are covered, but we don't know much or anything about those who do not participate. So we're still missing like a part of the picture. Instead, with household surveys, basically, usually we have a picture that is naturally representative. And in the case of household budget surveys, you collect information on a wide range of issues for persons with and without disabilities, and therefore we might capture those who participate and are covered under social protection systems, as well as those who are not. And that's why household budget surveys are quite interesting as a source for us to learn more about disability inclusion and social protection. At this point, we have to link, therefore, like the concept of disability with social protection. And usually the way it's done in survey instruments, broadly speaking, it's through two types of questions, let's say. The first one aims to basically assess needs for support. And this is done by, for instance, asking questions about like a specific domain and relate this domain with disability. In the case of employment, for instance, you might ask whether you had worked in the past 7 days, and you might answer that, for instance, you didn't work because of the disability. So in this specific example, you see that the domain employment and the question about employment, it's compounded with the question about disability. So you don't basically assess disability in isolation from employment. And this is therefore like something that could be useful for authorities to understand how many people might it can support, for instance. But if we want to understand whether persons with disabilities have same access and coverage of other persons with no disability and the social protection, basically we would need first, as in the equality of opportunities, let's say, approach to define disability status. And this would require like at least one question or a set of questions that define disability status, and then a separate question about, for instance, employment again, but would be like education or social protection, such that at the level of the analysis of data, we can then basically compare what are the outcomes for persons with disabilities and the outcome for those without disabilities. And this is what particularly we need if we want to monitor the Sustainable Development Goals, but also like the delivery and achievement of the Convention of the Rights of Persons with Disabilities. And this is something that I believe can be done by looking basically at household budget surveys again, because you have like the potential to measure and assess disability status along with other information related to social protection. So in this paper, what basically I did was to start from a repository that is publicly available and that's been built by the World Bank and brings together administrative data as well as household budget surveys. And so I focused basically on household budget surveys that were collected after 2010. And for each country with at least one survey, I selected basically the most recent survey. And you can see on the left-hand side of the graph that I had initially, let's say, 97 countries divided by regions of the world. And then what I did was basically to look at each questionnaire for each of the country to assess what kind of information on disability was included and whether there was like information on disability status, and last, if I had like data that I could use for analyzing micro data. And you can see that from the very beginning, from 97 countries, we end up basically with just 29 countries. So that means that initially I looked at, are there like any questions for needs assessment or disability status? And then moving right, you see there's a decrease in the number of countries. And then we are just left with half of the countries that I was considering for my analysis when I look at whether there's any question regarding just disability status. And the problem is also, of course, data availability and access to data, which is not always granted. So, I mean, this is definitely like an issue if we want to use this source to better understand what are the conditions of persons with disabilities and social protection. So basically my analysis will focus on those countries for which I have like a survey that provides information on disability status, social protection, and for which I have data. And in this slide, which I mean, like it's the last one of the presentation, I try to summarize the main takeaways, and then we can just take it from here for the discussion. But definitely you have seen from the previous slides that also budget surveys bring together like social protection, disability inclusion, and other information. But at the moment, given that not many of those include any information on disability, are to be considered like an untapped resource. And it's a potential that we should leverage if we want to better understand the condition of persons with disability, but if we want to push further social inclusion. And given that there are several differences in terms of how disability status is assessed and measured, as well as differences in the way information is collected for social protection, it's difficult at the moment to have like an international comparison. Can still be done for like a set of countries by standardizing sensor measures, but it's not like so straightforward. Instead, what we can definitely do with household budget services to better assess what is actually the condition of person with disability in each and every country. So this could be definitely used by national authorities to better understand, I mean, like who's left out and who actually is covered. And of course, in some cases, if you have like different measurement models of disability, for instance, the medical model and the model used by the Washington group, which is a short set of questions, you could actually just compare what are the disability rates on the basis of these two models, and at the same time, what are the implications then for coverage? Because you can see from like the column where I wrote basically from microdata, you can see that, of course, if you have different measurement models of disability, you end up with different, let's say, estimate for the same population. And that means that in terms of policymakers, policymaking, the efforts needed to reach out the whole population differs because, of course, if you have like an higher rate due to a measurement model, then the people that you need to reach are like in greater numbers. And this also affects, of course, who is covered, who is not covered. But again, it's fundamental to understand that if we have discrepancies in estimates due to models, then we might risk to leave out people just because we're not counting them. And then in terms of substantive results for the analysis, I basically looked at social assistance and insurance, and then basically looked at what are the coverage rates for households with persons with disabilities, and what are the coverage rates for households without persons with disabilities. And across the board for the 29 countries that I've assessed so far, I could see that basically the coverage among households with and those without disabilities is higher among those with disabilities. Rather than those without, and that's something that I didn't expect in the beginning to start with. So I'll just go back again to the data and then do like further analysis on this. And then, of course, also budget service as they are today are definitely just something that we can use and we should use increasingly for the purpose of understanding coverage and social protection. But of course, we need like to standardize even further how we measure disability and the model that we use for conceptualizing disability, which is still lacking at the moment. And at the same time, what could be very useful, and this is like a step that requires a lot of resources and efforts, would be also to integrate disability in sampling strategies, because at the moment, basically in household budget service, you lack this like disability stratum. But of course, this also requires a previous data collection to basically identify in the population how many persons live with disabilities, and that this information could be used to sample people for household budget service. So this is pretty much, I mean, like what I made out of the research that I've carried out so far, and it's very my work, but I appreciate your comments and thank you so much for your attention.
Thank you very much, Mario. You were 7 seconds away from the beep. That's a good start. You set a great standard for our speaker. Thank you very much. We have one comment from Daniel Mont saying, very interesting. I think that in addition to comparing difference in overall disability prevalence using different measures, we also should look at the overlap. who are identified by both measures, and who do each measure identify that the other people miss? I wanted to ask you, you obviously didn't have the time to cover all the work you've done. Have you looked at this issue of overlap between a different approach of measuring disability, Mario?
I mean, I did some preliminary analysis on basically 2 countries, which provide like for both at least 2 measurement models, let's say, and these are Albania and the other one is Bolivia. And of course, you can cross-tabulate and see, I mean, to what extent, I mean, the 2 compares. And I think that the best case for this kind of analysis at the moment is Albania, because it has like 1 question that is strictly speaking related to a medical model. So whether you do or you don't have a disability, and the other set of questions which are related to the Washington Group short set. And in that case, what I see, but it's still, of course, like very preliminary, is also due probably to the design of the question, because like as a respondent, you would be first asked if you have or you don't have a disability. And then among those who answered yes, then you would be like receiving the question related to the Washington Group subset. And of course, there's like an higher, like the rate is higher for like the medical model, which is, let's say, the skip logic question. And instead, the rate is lower among those who answered also for the Washington Group. And this could be related to a set of reasons, of course, which needs further investigation. But I think that that's the best example, probably. I mean, like I remember we saw the discussion aside from like the conference, Georgia might have something like this. And probably these are the most interesting cases because we can really compare what are the estimates, whether they do overlap. And of course, not just at the level of the rate, but at the level of the individual who is really just identified, because that really matters also for us if we want to standardize measurement, for instance, such as the Washington Group, which is also being championed by the UN.
Thank you very much, Mario. Indeed, I think what's also very interesting is in the last years, there has been quite a lot of work with people like you digging actually in household survey and census, and we are starting to get really good quality data. I think tomorrow there is this session on extra cost of disabilities, where there have been some in-depth look in household surveys, linking to everything you said. When you put the Washington Group or other disability measures in household survey, you can start doing this kind of quality work that really informs social protection. Thank you very much, Mario. We might come back to you after the other speakers. And for colleagues that are with us, if you have other questions coming up through listening to others for Mario and what he said, don't hesitate to bring that in the chat box and in the question and answers. So I would like to go now to Maldives, which is difficult under the current circumstances, but some people have been had the chance to work there. It has been a common joke with Morgon over the years. And I would like to ask Shaffa Hameed to tell us a little bit about the research you did on access and impact of the disability allowance in the Maldives. Shaffa, the floor is yours.
Thank you very much, Alex. Let me see if I can share my screen. Give me 1 minute. Sorry. Can everyone see the slides?
Yep, we can see the slides, Shaffa.
Thanks again. I might have to talk a little bit fast, but please make me slow down a little bit. So I'm here to talk a bit about access to and impact of the disability allowance in the Maldives. And this is research I did along with Morgon, who is also here, and Professor Hannah Cooper. So overview of the session, bit of background, methods, results, and then questions. So I've provided a couple of maps here. So as you can see, Maldives is a group of islands, and from the other map, you can see how small it is compared to India and Sri Lanka. So it has a population of over 400,000 people dispersed across 200 islands. A third of the population live in the capital, Male, where central government and tertiary health facilities are based. It's categorized as an upper middle income country. So the social protection programs are under the administration of the National Social Protection Agency, and this includes the Disability Allowance Program and the Medical Welfare Program. A bit more background into those programs. So the Disability Allowance is a cash transfer, a monthly cash transfer of 2,000 Maldivian rupiah, which is equivalent to about 130 US. It's non-means tested and non-conditional. It's only available to Maldivian citizens. Entry to the program is by application, which includes submitting medical certification of impairment. Once they apply, people are assessed by a government committee as having a disability. So people with disabilities may also receive other benefits separate to the disability allowance. So these include other social protection schemes such as the old age pension for those over 65 years. And the medical welfare program is a separate program implemented by the same agency. It is non-targeted, so it's also available to non-disabled people to get assistance related to medical care not covered by the National Health Insurance. So this is the program that provides assistive devices, though this requires a separate application. It is less well known that the medical welfare program can cover the costs related to the medical certification required for the disability allowance. So the objectives of the study was to assess access to the disability allowance and to explore the impact of the allowance through 3 outcome measures: poverty, quality of life, and participation. It was a quasi-experimental study design, and we collected data at baseline 2017 and 2019 endline. The baseline study included national population-based survey of over 5,000 people. We used the Washington Group questions, the extended set. We identified people with disabilities across the Maldives and if they are accessing the disability allowance. We also had a nested case control study to compare between people with and without disabilities, and they were matched by gender, age, and location. For endline in 2019, we revisited all cases and controls and new enrollees to measure the change. We also had a qualitative research component, so I conducted 40 in-depth interviews at baseline and endline. In order to determine impact, we did difference in difference analysis to compare changes across 3 outcome indicators: poverty, participation, and quality of life. So the intervention group are the people who didn't receive the allowance at baseline, but were now receiving at endline. We compared them with people with no disabilities and people with disabilities who have never enrolled for the allowance. First, let's look at access. So the prevalence of disability was found to be 6.7%. However, the coverage of the disability allowance was just 25.6%. Coverage was lowest in the city, Malé, compared to the other regions, and women were less likely to receive the disability allowance. Children and young adults were most likely to receive it, and we found very low coverage in older adults. The qualitative data highlighted several intersecting factors contributing to this pattern of access. As common in many contexts, there were informational barriers that affected uptake. How to apply, where to apply, or even what the disability allowance is. The implementing agency typically communicated this through registration drives. These are more common to islands, which might explain why there was higher coverage in islands than in Malé. Another key challenge was confusion over the eligibility criteria, which had not been made publicly available. Some respondents felt like they would not be considered as having an eligible disability and therefore did not apply. Most common perceptions were that an eligible disability would be something you were born with, and that limitations needed to be extreme, for example, being bedridden or nonverbal. Some felt that invisible disabilities such as pain would not be recognized by the program. Many also identified as being old, not disabled. This is linked to the incorrect perception that they are required to choose between receiving the old age pension. Misconceptions about eligibility criteria was common, and in small island communities where everyone knows who is getting the allowance, this created stigma. Respondents who want to apply for the disability allowance reported concerns about facing criticism from others in the community, particularly if they don't think that person does have disability. For example, people may not accept a worsening condition that had stopped them from working, or they may be compared to another person in a worse situation. This perception that having a disability alone does not qualify one for the allowance, and that recipients are not always people with disabilities, this created mistrust in the program. This in turn contributes to self-exclusion among eligible people and reduces the access to the program. The geographical dispersion of the islands also affected access, and this is also linked to the financial barriers. So most specialist services are located in Male, where it is costly to travel to and to stay. So this created barriers to getting the necessary medical certification required for the application. Conversely, there is also evidence that poverty can sometimes drive enrollment. For example, some respondents did not apply because they felt their financial situation was sufficient to meet their current costs, or that the additional income received through the allowance wouldn't make much of a difference in their standard of living. This lack of perceived need for the cash transfer might be why coverage was lowest in Male, even though many barriers to access, like the geographical barriers, are reduced. To go into impact. The first indicator of impact we considered was household poverty using the national income poverty line. Here we can see that there was a decrease in household poverty for all three groups between baseline and endline. New disability allowance recipients, people without disabilities, and people with disabilities who had never enrolled in the program. For example, poverty decreased in new recipients from about 52% to 35%. However, because all groups experienced this decrease, the difference in difference estimates, which included adjustments for gender, age, and location, indicate that there was not a statistically significant impact of the allowance when using either of the control groups as a comparison. We also see that at both endline and baseline, new recipients were most likely to be living in poverty compared to the other groups. So there was no impact of the disability allowance on poverty or on overall household spending. However, the allowance did decrease household spending on healthcare. Turning next to quality of life, which was assessed using the WHO QoL-BREF, we see little change in values between any of the three groups over time. New recipients reported a score of about 51 to 52 at both time periods. People with no disabilities are at about 70 to 72, and people with disabilities not receiving the allowance are at about 62 to 63 points. Again, we are seeing that new recipients had the poorest outcomes at both time periods. Unsurprising, given the lack of change for any group on quality of life, there was no significant impact attributable to the disability allowance in the difference in difference estimates when using either comparator group. Looking at the impact on health, the disability allowance decreased the likelihood of experiencing a negative health event in the last 12 months among adults over 50. It also showed some positive impact on overall health-related quality of life. We also included indicators on participation. For example, participation scores were created using SINTEF tool, which looks at participation in home and community life. Scores were consistent across baseline and endline for all groups, with new recipients having the lowest scores. There was no measurable impact of the allowance on participation. Finally, there was no measurable significant impact of the allowance on work amongst working age adults. About 25 to 30% new recipients were working, compared to about 55 to 60% of people without disabilities and 42 to 47% of other people with disabilities. Employment status was fairly stable for groups across time. So I'm going to go through some of the qualitative findings that kind of go into more depth about why why we're seeing low impact. The first reason is the most obvious one. So it's a low monetary value. So the amount of cash transfer, the value of the cash transfer was perceived to be relatively low. So this was $130 per month, particularly because intervention households were more likely to be living in poverty. And they also had to contend with extra costs of disability, such as assistive devices, rehabilitation, and personal assistance. This quote is from a mother of a teenage boy with a mental health condition. She was telling me about how her son had lost interest in school. I asked her if she knew about some other classes run by NGOs, and this is her response. That's money too, isn't it? How can I enroll him? There is no money. Even now, I'm not able to make ends meet. Rent is $500. Electricity comes up to $200. And to be honest, my salary actually comes up to about $400. We cannot manage on that at all. We can't do the things we want. Secondly, it was common to find that the funds, the actual allowance, was not usually controlled by the beneficiary. So spending may not have been on the individual, but might have contributed to the household, to other household needs. So it was assumed in the theory of change that being able to contribute to the household pot will give a sense of empowerment and dignity to the beneficiary. But the data indicates that for many, this dependence and loss of control and autonomy overpowers that. So the cash transfer may have actually limited individual benefits. This quote is from a young woman with a visual impairment who was described by her caregiver as a sick child who didn't really know much. But after the caregiver was sent away, she talks about struggling to gain that autonomy. So she says, so I've been getting $130 since I was in grade 5. So think about it. Every year I would have got $1,500. And how many years has it been? So I asked, so what is that money being spent on? She says, it is not being spent yet, but that money was in my father's account, and he has bought a motorcycle the other day. That's because his money and my money were kept separate. So, and then she continues to talk about how she struggles to get autonomy and to make a decision about the money, how the money is spent. To go to the last one. So lastly, at a broader level, there is a lack of disability inclusive planning. So the scarcity of services available to islands mean travel to tertiary hospitals in Mali, especially if requiring rehabilitation and services such as physiotherapy, speech therapy, and counseling. So this quote is from a caregiver of a child with cognitive impairment. They can't afford to move to Mali, which means their child is not getting the services he needs. So this has also built up the therapy sessions in their mind, and they speak about it as if it would fix him, and they feel guilty that they can't afford that fix. So I ask, how much do you spend when you go to Mali? And then she says, it's usually for that long, about a week. It does cost us a lot. It's difficult to say how much exactly, but it usually empties everything we have, because that includes tickets for both of us, return, and our stay in Mali, and food. So yes, it's a lot for us. And when I ask if they have any savings by the time they return, she says, we come when we are nearly out of money. We come when there is no other way, when we have reached a point where we can't stay in Mali. So just to summarize, access to the disability allowance is below need, with gaps in coverage highest for women, older adults, and Mali residents. The impact of the disability allowance is limited, with some positive benefits for health. And this impact may be strengthened through improving benefit package and delivery, strengthening referrals, and investing in broader disability inclusive planning. And that's about it. I hope I made it on time, actually.
Thank you very much, Shaffa. You made it on time. Perfect. Thank you very much for this presentation. We do not have yet specific questions with regards to your presentation, but I think what I find really interesting is cash is not everything. And I think when we think social protection and disability, very often the first things that come to mind is the disability benefit. And the latest work, and I think this research is really highlighting that, is that it's a critical component but it's not sufficient. And for many people with disability, lack of access to support services is really critical. I think also, as you mentioned, and I think Morgon will touch upon that tomorrow with regards to cost of disability, there is probably more work to be done of what do we mean by adequacy of disability benefit? How much is enough? And can it be the same for every group? So I wanted to ask you, did you see significant difference between different groups of persons with disabilities? You mentioned children and working age adults, for instance, or older person, but for instance, person with more significant support needs compared to others, person with different kind of functional difficulties. Did anything like strike, or was it across the board more or less the same type of findings?
I think it was mostly the same, but I am going to let Morgan speak to you a little bit about from the quantitative side, if that came through a little bit. Morgan, are you around? Yeah.
Yes, so that's a really great question. The challenge that we had was in the sample size. So we really would have liked to have been able to disaggregate by different types of disabilities, but from the quantitative side, we were unfortunately unable to do that. So I think that's for sure an area for future research, seeing how the impact differs for different groups. There were some differences by age and gender. I think age, one of them was around health. And I think a lot of the decreases in health spending and improvements in health were, I believe they were stronger for women than for men. But the disability types, I agree, is an area that is worth looking into more.
Thank you. And while you're there, Morgan, Karen is asking a question to you and Shaffa. Were the characteristic of people with disability with and without the getting the allowance, was it the same?
No, so they were quite different. So people who were getting the allowance were more likely to be men. They were more likely to be a bit on the poorer side. So not the lowest by the lowest socioeconomic status, but I think it was the second lowest quintile. And they were more likely to live in the islands. I think they were more likely to have cognitive impairments. I think that was the most common, less likely to have sensory.
Okay. Thank you very much to Morgan and Shaffa for this great presentation. So this last question, I think, leads us to this next presentation about social protection doesn't work the same for everybody. And we know that within the community of persons with disabilities, some people face much higher support requirement, but also much more barriers in accessing the support they are entitled to or that they need for basic participation. So I would like to ask Karen and Sandra, who are both working with the University of South Wales in Sydney, to tell us more about the work you have done with regards to the NDIS and the access to most marginalized groups. Karen, the floor is yours.
Thank you very much, Alex. So today I'm just going to share my screen, and I'm going to start with the presentation, and then Sandra is going to join. Right, can you see the screen now?
We can see it, but in a presentation mode, which
Great,
means...
thank you. Whoops, just go back. Okay, so thank you very much. Today, what we are going to talk about is in Australia, we have a very big disability policy reform, which intends to set out universal disability service provision. But of course, people who are most marginalised from services are much less likely to be able to access it. So it's a very interesting opportunity to be able to observe how we might be able to help these people to receive services when we know that they are most likely to miss out. So what we'll talk about today is just to first introduce the National Disability Insurance Scheme, the NDIS, then talk about the people who are most marginalised and the intervention to try to assist in that problem, briefly about the methods, and then I'll hand to Sandra to talk about some of the findings. So the National Disability Insurance Scheme is free services, disability support. It's through it's a public health insurance scheme, so it's through general taxation and an income tax levy. So it is meant to have universal coverage, either through a specific support package or a referral to mainstream services. Income support is separate. Although it's universal, in fact, what we expect is that about 10% of people with disability will receive the income support package. These are people with permanent and significant disability. They can either manage it themselves or have some type of intermediary, and they can use it to buy services from the market or to employ a support worker. So what this means is that still 90% of people with disability are expected to be referred to mainstream services and rely on information and referral. What that means, of course, is that most people with disability, even those who have significant disability, remain marginalised from access to NDIS. And the reasons for those barriers are the usual ones around structural barriers, such as where they live or their contact with criminal justice system, social barriers, such as not having social networks or support that enables them to find out how to use services, or they may be homeless, or they just don't have the information. And then personal barriers, particularly for people who don't identify as having a disability, which we heard about in the last paper. And particularly in this case, people with psychosocial disabilities or mental health needs, especially if they also have socioeconomic disadvantage. So we participated in a action research project called Enable In. And in that project, the aim was to engage people who have psychosocial disability, particularly homeless people, to let them know about NDIS. The intervention itself was one-to-one support with people in person or by phone or through peer support. Intensive support and referral through those groups or through service providers that they may come in contact with. Assistance to the people with disability or the service providers to help them understand about what NDIS access might be. And then training to service providers and advice to people and providers about how to continue to help other people to access NDIS. The research method was that we looked at, particularly at the question, what project elements are needed to reach marginalised people who are entitled to access publicly funded disability and other social support. We used collaborative research methods with a disabled persons organisation called People with Disability Australia, and with collaborating with the university researchers and people with disability who had relevant lived experience. Those people were involved in the governance, the project itself, and in the research design. and we used the usual range of mixed methods of interviews, observations, case studies, and program data. This is a table with that summarizes the data methods and sample. It was conducted over 2 years. As I said, it was action research. And we were able to include a range of methods so that we could see from different perspectives whether or not the project was effective. And I'll hand over to Sandra to talk about the findings.
Thank you very much, Karen. So on the next 3 slides, I will speak to some of the successful project elements. So in the analysis, when we looked at the case studies, interviews with people and stakeholders, what we found was that relationship-based elements made the project a success. So first, relationships played an important role. That meant that building quality relationships was a key ingredient to connect to and support people who had experience of homelessness or psychosocial disability. So that relationship. Another factor were time and trust. So we found that often for the project staff, the Enable-in staff, to develop those relationships, it took quite a long time. And so a couple of months or several months even to develop that trust between workers and the people they supported. And this was mostly due to the fact that people had experienced unreliable and poor quality of services in the past. So they had developed a strong distrust in services and in the support system overall. And time was also key for people to understand and make relevance of the concept of disability to their own life and what that could mean for them to access publicly funded support. And we heard that in the last presentation as some sort of self-exclusion to seek support, where people thought this is not for me, this is for other people. So I'd like to read out a quote from one of the people in the project, supported by the project, how they experienced this, the support they had received. I have received one-on-one time from Enable-in. I found the staff was someone easy to talk with and trust. They are very empathetic to me. I felt listened to and heard. After almost 10 months keeping in touch with Enable-in staff, I feel that I'm ready to trust someone to use their judgment to connect me with services. So that really encapsulates that sense of relationship and time. Karen, next slide, thank you. So the second element that we identified that made the
I don't like this piece.
Enable-in project a success was, Alex, sorry, did you say something?
No, somebody else messed up with the mic, sorry.
Okay, so the second element were the service networks that we identified that, so overall, all stakeholders interviewed in the research, they identified there was a common gap to effective support for people who can, most marginalized groups in society. And stakeholders said there was a disjunction and limited capacity of services from disability, homelessness, and health services to work together to support a person more holistically. So in the Enable-in project, the staff worked really, or the workers worked hard to collaborate with other key services around a person's whole of life needs and preferences. For example, by attending case conferences, linking in and following up with health providers that were essential, for example, also to not only the overall well-being, but sometimes to access other services. People needed to be referred or things like that. So they really made their work around the person's need and their goals. The project staff also collaborated with homelessness services to demonstrate the good practice they were doing at the locations and venues where people were most comfortable. So, for example, those were weekly food deliveries or food trucks in parks that you have in Sydney, or a community venue at a church where they have barbecues. So they use those venues to provide actually that in-depth support, intensive support. So here's one of the staff, and we've taken out a quote that demonstrates the level of support they provided in the project. Intensive support is central to working with people from hard to reach communities, as they all have multiple support needs. Some of the outcomes of providing this support includes building confidence and empowering people in the situation they are in, but also making time to connect with other organizations involved in a person's care. So yeah, that really shows that the practice that the project applied. So this last slide, in terms of what made the project a success, is about peer leadership and peer involvement. So people with lived experience of homelessness or psychosocial disability being part of the project in all sorts of ways. So one of these ways, the project had a component where they trained people with lived experience to become leaders, peer leaders. Oh, sorry, my technology just collapsed there. So to become peer leaders in their own communities. So the project trained people who then went out to provide information and build confidence of other people in their communities to seek out disability and NDS and other supports in their life. People with lived experience were also part of the project governance. Karen mentioned that already earlier. But an important component to them feeling valued and a part of the project was not only their presence, but that their time and their travel cost to attend these bi-monthly meetings was compensated for. So it really gave them a sense of ownership of the project and directing, having an influence in how it is delivered. And then thirdly is, as a result of the different ways of involving people with lived experience to become peer and leaders in the project, they reported that they had gained confidence, knowledge, and built friendships with each other. So here's a quick quote from one of the peers in the project who reports how they experienced delivering information about seeking out services to some of their peers. I think they found it easier to speak to me because I'm like, well, I get it where you're coming from. I've had these experiences in life. So that part I really, really enjoy, where he speaks about supporting other people. Now, what does all of this mean? So we've summarized the implications for engaging marginalized people more broadly, as we saw from this project. So the first is what we've heard today already, the concept and practice of disability support need to be provided within a much broader context of social services, but also a whole of life needs approach, where the different support needs are not categorized in this is health and this is school and this is participation, but it's taking the person and their interconnected lives as a whole and trying to support them in that way. The second we discussed here are the strong working relationships between services and between workers and the people they supported. that was very fundamental component to building trusted relationships, engaging people, but it also required a lot of time and resources, so funding for services to be able to do that. And then thirdly, we identified that disabled persons organizations and other advocacy organizations are a possible source of this type of expertise that we've spoken to about today, this kind of whole of life needs approach, working with a person holistically. Because many people trust disabled persons organizations. So these can respond more flexibly to individual and systemic barriers and opportunities. So they are an important part of, they remain an important part of the system.
Thank you very much, Sandra.
Thank you so much. I hope I haven't used too much time. The last slide is on the resources, and please get in touch with us and ask questions, and we love to hear from your work. Thank you.
So we actually have, thank you very much. We actually have one question already. We have been granted 5 minutes extra for time, so we will make good use of it. Did your study include indigenous Aboriginal people with disability? If so, how did you locate culturally appropriate services?
Is that for me? I'll answer that question. Karen, jump in. Yes, there were a small number of, or there was a number of Aboriginal people and Indigenous people involved in our study. And they did, the workers collaborated with Aboriginal organizations, but also some of the people supported by the project, for example, in metropolitan Sydney, were accessing community services, so homelessness support for all open to anyone. So I think there was, they tried to work with specific organizations for Aboriginal people, but as well, had quite a lot of provided support where in community kind of settings. Is there anything, Karen, that you wanted to add? I hope that answers the question.
Thank you. Thank you very much, Sandra. We are 5:32. There was one more question that we didn't address that referred to the previous presentation from Daniel to Shaffa and Morgon. Do you know what drove the decision to have a non-means tested universal disability allowance? Because we know that it's one big issue. For instance, we see also in Australia the adoption of universal type of system, which is what we would like to see. But in many countries, there is means test, there is poverty targeting of disability support. Do you know what made the Maldives go for a universal type of scheme?
I was just typing my answer to that when this came up. I'm not sure I have a definitive answer. I think it's a really great question. And actually the disability allowance is just one of the few social protection programs that are not means tested. So the single parent allowance is as foster parents and a couple of other ones. So I'm not sure. I think, and it's quite interesting because before this was written into law, the social protection, everything came into law. The disability allowance in its kind of informal form was more means, not means tested, but only as a benevolent acts by the government body to people who needed it or who asked for it. So it's quite a big change, and I'm not sure I have an answer to that actually, but it's a really great question. I'd look it up.
Thank you very much. So with those, we will unfortunately have to conclude this session. Thank you very much to all the speakers. I think there are several sessions tomorrow on poverty and inequality, on extra cost of disability, and long-term care that are really important, I think, complement to put social protection in perspective. I just would like to highlight one of the last points Sandra made, is that social protection for persons with disability is not just the job of social protection specialists. And I think the more we can engage with organization of persons with disabilities, it will help also a greater understanding of what is a rights-based approach of social protection, because within organization of persons with disabilities, it's not always clear. But one thing that we saw very much during COVID-19, and one thing that the research of Sandra and Karen showed also, is that if you want to reach out to persons with disabilities, if you want to connect, organization of persons with disability, peers, can really play a great role in supporting social protection system being more inclusive. So I think this is a conversation that needs to continue. Thank you very much again to all the speakers, to all the attendees, and to Fordham and Columbia for this opportunity. Thank you.
Thank you, Alex. Thank you, everyone.